The shoulder is a very mobile joint because it's a ball and socket joint. Examination begins with careful inspection, looking for any obvious deformities from side to side. Obviously, it's very important to expose the whole body. And again, looking from side for any deformities. It's also important to look for the scapula, which is an important part of the shoulder. We're looking for scars, swellings, any deformities, any masses, anything unusual, and any asymmetry in the muscle length. We then begin by palpating the major points, starting with the sternoclavicular joint, feeling along the clavicle, and then feeling around the humerus. Here, I'm feeling around the humeral head, and then also feeling along the biceps tendon. Then, it's also important to feel around the acromion and then the coracoid process, again trying to elicit any pain during this examination. Here, this is me looking at examining the shoulder laterally. Finally, we should feel the scapula. Again, we compare both sides to see if there's any asymmetry, and any asymmetry in muscles. Feel along the spine of the scapula, and then along the edges of the scapula, medially, and also feeling around the inferior angle of the scapula for any pain. While in this position, we can then assess the movement on the scapula. We get our patient, in this case, to do different movements, such as shrug superiorly, inferiorly, anteriorly, and posteriorly, just to compare any movement of the scapulas and look for any dyskinesia. Next, we move on to our movements, starting with passive. Forward flexion, as far as we can go, comparing both sides. Then, we can look from the side, and again look at extension as well, looking for how far the patient can go. We can also test for abduction, and then we can also test for adduction of the patient. Other movements that we can do include internal and external rotation, and this can be done. This is done from the back posteriorly, comparing both sides, and then over the top. This patient has a good range of internal and external rotation. Our patient here is showing his range of internal and external rotation from the front. Now we move on to active movements. It's important to try and stabilize that scapula, and here we can just assess how much movement there is of the glenohumeral joint in flexion and extension. My arm being placed on his scapula there restricts it and restricts the movement to just glenohumeral joint. And we can also assess for abduction. Glenohumeral abduction and glenohumeral adduction. Again here we're stabilizing the scapula in this position. Then we can test internal and external rotation. Internal and external rotation are again shown from the front. Our next part of the examination assesses for resisted movements, and I guess assesses the power of the strain. Here we're testing for resisted power of flexion and extension of the body. Next, we're testing for glenohumeral abduction, the power, and at the same time, then we test for adduction, seeing if there's any weakness. I can then test internal and external rotation resisted. Here, we're trying to elicit any pain or any pops or clinks while we're moving the shoulder. Next, we can move on to our special tests. This is the Jobe or empty beer can test, which looks for any rotator cuff tendinopathy. We can then assess for the painful arc. The painful arc assesses for any pain during the abduction of the shoulder to see if there's any pain which might be suggestive of rotator cuff injury. Next, we can then do Neer's test, as we put the patient in forced flexion and look for any subacromial impingement. Hawkins' test is then used when we put the patient in 90 degrees internal rotation while in flexion and try to listen any pain which might be suggestive of impingement. Finally, we can look for GERD, glenohumeral internal rotation deficit, and we compare both sides which might be suggestive of any tight posterior capsule injuries. Again, There's no deficit in glenohumeral internal rotation deficit seen here, but we might use a goniometer to assess for formal assessments. The belly press test, as shown here, is another type of test which can be used to test for subscapularis injuries. And finally, the Gerber push-off test is another test designed to try and elicit pain, and this can be used to isolate the subscapularis. Next, we test for instability. By pulling down on the arm like this, we're looking for the sulcus sign, which might be suggestive of instability or dislocation of the shoulder. The apprehension test here is designed to try and mimic movements which allow the shoulder to dislocate in the first hand. And then we can also translate the shoulder anteriorly and posteriorly to see how lax the joint is around that side. Then we can move the patient into a position on the bed where we can also do different ways to assess for laxity of the shoulder. Again, we try doing an apprehension test where we put force posteriorly through the backside of the shoulder to try and mimic that dislocating movement. Here, if it's a positive test, there may be pain or the patient may be very resistant to this movement, which might be suggestive of dislocation. Finally, I do a clunk test, which allows me to move the shoulder in various different directions, looking for any clunking, pain, or popping, which might be suggestive of pathology of the shoulder. Again, we try and translate the shoulder in this position anteriorly and posteriorly, looking for any more instability. The final test that we do is the Hawkins test, and this test is used to assess for any slap tears by turning the thumb down and pressing down, and the slapprehension test, which if positive or relieves the pain, might be again suggestive of slap. Finally, we move on to our functional assessments, looking for kinetic assessment, starting with squats, single leg and double leg, looking for any asymmetry or deformities. Then we look for the side, looking for any posture deformities, looking for the curvature of the spine, and any other abnormal structural alignments. A functional test of a pusher is also useful to determine if there's any abnormalities of the shoulder. And finally, a prone hold or hover can be used to assess core stability. If there's a disrupted core stability, it might place the patient at risk of further injury. Finally, as part of this kinetic assessment, I assess the range of the movement of the neck, both anteriorly, posteriorly, and side to side. My final part of my kinetic assessment involves trunk rotation and then flexion of extension. That completes my shoulder examination, and I would also consider doing radiological and other examinations of the upper limb.